Well, hello and welcome to another edition of Health Solutions with Sean and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Sean Needham, along with my wonderful wife, Janet, and we are streaming live from the Moses Lake Professional Pharmacy Studio. And I'm super excited to have our guest on today. You don't want to miss out because he is actually co-founder of Wellbridge Surgical Center in Indiana, and it is another free market surgery center. If you guys follow us often, we talk about the Surgery Center of Oklahoma and Dr. Keith Smith, who since 1997 has had a surgery center where they got out of the traditional healthcare racket and offer patients a big savings by paying directly. So we have Dr. Piniecki on, who is an anesthesiologist and the co-founder of Wellbridge Surgical, and we are going to learn about their store today and how they can save people money and how they are better quality and a lower price and yet better service. I know we talk about it often in free market medicine, and we talk about it often in just services in general, that you can usually have three of the two. You can have low price, high quality, and good service, and you can usually have two of those three. Well, let me tell you this: in free market medicine, you can have all three of those if you choose to pay directly. And Dr. Piniecki is going to show us how today. So, Dr. Piniecki, welcome to our show.
Thank you. And yeah, thanks for having us. Appreciate it.
Yeah. So tell us a little bit about your story. I think you guys have been open for a couple months now, and just tell us about that journey and what brought you into opening up a free market surgery center.
Yeah, sure. I appreciate it. Yeah. It all started probably about 4.5, 5 years ago. I was introduced to the Free Market Medical Association, the FMMA, and at that time, or shortly thereafter, the subsequent year, went to one of the conferences and met Dr. Keith Smith. And the impetus for doing that in the first place was, I'd spent about 10, 11 years in medicine by that point in practice, and realized that, the trajectory that we were on was non-sustainable. And really, I was getting less and less kind of enamored or less enjoyment from the actual practice of medicine because, as you start to learn about the business of medicine and how the process happens and the patient experience, the cost, the pressures applied to patients with time constraints on medicine, you realize that the system's fundamentally broken. And so I didn't really know what the solution was until I started doing a little research on, the free market medicine kind of drive or ideals. And so Keith Smith obviously was up and running at that point in time, and his surgery center was very successful. And he talked quite a bit to both myself and Dr. Inman, who's also co-founder of the business, about how he did it. And it really kind of lit a fire in us that, there is a way that we can practice medicine the way that it should be. And what I mean by that is no longer limiting accessibility to care. And when I say limiting accessibility, not just financial, obviously that's a huge hurdle, and that's one that we're striving to solve. And I think we're starting to already by decreasing the cost substantially, but also by just opening up access. So patients have a portal, a phone number where they can reach out directly to us. They're not put in a queue from 3 months from now to see a direct, or to see a primary care doc. We have relationship with direct primary care docs that are willing to see them right away, and surgeons who really buy into this as well. So we have a network of medical professionals around us that really allow us to kind of fast track patients through the system and explain to them the process along the way, not just told, hey, you go here in 3 months and then wait for the next step. Literally answer their questions, listen to them, and get them plugged in to see the specialists that they need to see.
So, Janet, do you have any questions for Dr. Piniecki?
Well, always in a story of where we end up in the free market, there's something that made you decide, like a final straw. I know Sean and I have shared this story. We had a patient that called us, and you know, I I remember when Patty called and she gave us her goodbye. She actually was passing away. She was morbidly obese, and I had taken care of her for many, many years, and I thought in my mind, am I a part of this issue? Am I a part of the broken system? Did I enable her to stay in her lifestyle that really harmed her and put her in the grave? So what hit you to wake up your eyes to say, okay, was it several things, or was it just one day it was just, I'm done?
It was a series of events kind of that happened. The first part of it was like I was telling you about, or alluded to a little bit earlier. You start realizing how medicine, the business of medicine works, and patients start feeling the effects. So it was not uncommon that I would get asked by patients, "Are you a network?" Or will my anesthesiology bill be covered by this hospitalization, or in this hospitalization, or will I have to pay out of network fees? And I said, well, of course, we don't practice any place that we're not currently, a network with from a hospital system standpoint. But I didn't really understand the question so much. And really, it was as I started researching that I found out, patients sometimes are charged exorbitant rates just because of the terms of their insurance. Right. And so it wasn't uncommon that, if a patient didn't submit the insurance information properly, that they might get a bill for 3 times, what the normal reimbursement was for any given procedure. So those kind of things happen regularly. Multiple times patients have said to me, hey, I know I'm just a number. And I really didn't know how to respond to that. Why would you think that? And, you're not just a number, you're an individual, you're a person that matters. And, as most medical professionals will tell you, when you go into the field, whichever specialty you choose, the idea is you're taking care of people. Mm-hmm. I like to be able to say that, I have one patient at a time in the field of anesthesiology, and you're my sole focus. And I tell patients that all the time. I said, I love the field because I get to focus on one patient. I'm involved in a very detailed manner in your care. And my goal is to get you through this safely, and as comfortably as possible, and with the best outcomes. And so those things happen. And then, it was incremental issues with the hospital systems that I worked in. It used to be that we could practice evidence-based medicine, and that slowly got eroded by cost factors. A lot of the hospital systems no longer really wanted to hear about new medications that have better outcomes in our field because they cost more. Some other things that happened, we tried to practice conscientious, I would say, in our field, conscientious medicine, meaning that like certain drugs in certain sizes cost more than other sizes. So we use a common induction drug, propofol, that's used in probably 90+% of surgeries every single day. They come in multiple vial sizes. It used to be 10 years ago, I could ask a hospital, would a 20 ml vial cost more or less if I use 2 versus a 50 ml vial? And they would tell me, and they'd give me the cost for each of those drugs. And it got to the point where just 2 years ago, I asked for that same information because prices always change. And they said, we're not allowed to disclose that information to you. And I said, well, wow. Why is that? I said, my goal, I don't benefit from this in any way. I'm just trying to save cost. And they said, well, that's proprietary information within our health system. And we don't disclose that information to you. And so it got to the point where, my practice was kind of limited from a diversity of medications. I couldn't choose evidence-based medicine as an approach in a lot of situations. And but it really wasn't until we actually started the development of the business that kind of the teeth came out of the healthcare systems. We decided to do this, and Dr. Inman and I and Jeff Williams, the third partner in the business, purchased the building, started remodeling it, and said, we're going to do free market medicine in a surgical sense and offer cash payer prices that are freely advertised and all inclusive, that are the same for everyone across individual procedures and across individual medical specialties. And then the hospital administrators, when the website went live, reached out to us and said that you have to cease and desist. And I said, well,
wow.
I said, I don't really understand that, but should we at least have a conference about it, a conversation? So we did. And we met with some of the high-level multi-state leadership within the healthcare system that we were currently a part of as a private group. And they said that we don't believe this is consistent with our mission. And I said, well, can you define that? Because if your mission is to increase accessibility to care and decrease costs, then we're 100% aligned. And they said, well, we have a system in place for those people who can't afford their care. And they choose their words very carefully, you know. And I said, well, what does that mean exactly? And they said, if you meet certain criteria, and I looked up the criteria, and it basically meant if you were truly indigent, if you really had no assets, you had nothing, then yes, you could apply for basically free healthcare or surgical care. But anybody that had any kind of gainful employment, they would put you on a payment plan that basically would handcuff you to 15, 20 years or more of debt for a surgical procedure that could be done in an hour or two in an outpatient setting. And so our response to that was, we are not competing for commercial insurance or government insurance patients. We literally want to increase accessibility to care for all patients that otherwise wouldn't have insurance or that just didn't have access or couldn't afford the cash payer prices of the current health systems. And we have seven large healthcare systems in our city. And I said, our target obviously isn't to pull patients from any one system, but there's patients from all around the city who either forego care or who are forced to pay a price that's actually substantially higher than any insurance reimbursed price for any given procedure. And so we just want to give those patients an option. And it just wasn't received well. They said that that's not okay, and we just don't think that you can continue to do that. And one of the things that we said is that, well, we are a private group, and we feel that this is something that's a good thing for medicine. And the response to that was, well, if you're going to continue, then we will leverage any authority, any control that we have in a financial sense with the larger group that you're a part of, is really what it boiled down to. And so when it got to that point, Dr. Inman and I both said, I don't want this to financially impact any other partner of the group. We had not broken any contractual terms with the hospital. Our privileges had never been in question or revoked. And so we said, I think it's just time to step away and kind of do the right thing. And yeah, in a nutshell, that's kind of how it played out.
Wow. It's just amazing. It seems like to me that hospitals just don't like competition, and you guys are just competition for them. And I think it's amazing too how you say their wording that, in indigent patients, how they'll give charity care. And I love how hospitals do define charity care. And we actually had a former hospital administrator on our show to talk about how hospitals define charity care. And it's a lot different than what most people think. But what's amazing too is with a lot of commercial insurances now, is, there's deductibles up to $10,000. So there'll be people that'll go in for a, routine surgery that, pretty simple, pretty straightforward. And it's, if they do it with in a free market setting, they can pay $5,000 or $6,000, and in the hospital it's $40,000, and then they end up having to pay $10,000 deductible. So that's an instance where that indigent patient wouldn't really qualify, yet they're out $10,000 anyway because of the deductible. They would be better off going to a system like yours, correct?
I think so, and I can give you like a very specific example too.
I would love that.
We just 2 weeks ago, I took care of two children. It was a family had two children. One was age 2, one was 9 months old, and they both needed ear tubes, recurrent otitis, recurrent ear infections. Been on antibiotics repeatedly, and were at risk for causing long-term hearing issues and damage if they didn't have ear tubes placed. Well, they didn't have insurance. And so they called us and were interested in our price for having ear tubes done. We did a little homework, and we found out that across the 7 hospital systems in our city that the average price within a few percent was about $6,800. That was the cash payer price, $6,800 roughly. Some are a little higher, some are a little lower. But they were remarkably similar, like within just a few percent of one another. In fact, some of the prices on some of the procedures are exactly the same, which kind of fascinates me as well when it comes to pricing transparency. Like, how is that possible, that it could be exactly the same amount? But the price was, like I said, about $1,600. We are able to perform that same procedure, bilateral myringotomy tubes, for $2,380. And so essentially, both children got ear tubes placed for less than the cost that it would have been for one child to have it done. They got it done sooner. And what's kind of fascinating about it is it's actually the same surgeons, because many of the private practice surgeon specialists in the city practice at multiple hospital systems. So those that are not employed or not obligated are limited by any non-compete. So they're absolutely interested in working at a new surgery center with kind of the goals and ideals that we have. And so same surgeons, new facility, better patient accessibility, and time to surgery. And I think over time, we're going to be able to perform or to show better outcomes as well, as we track that data.
Now, one thing I ask is that when you were, we commonly talk about this on our show. When you asked the price, did you ask about all exclusivity? Did the price of that surgery include the surgeon's fee? Did it include anesthesia? Did it include, imaging if that was involved? Because that's how hospitals get you. They, I know when our son broke his leg last year, 5 different companies probably. We had bills from 5 different companies. So did you clarify that part? About, was it all inclusive? Was that $6,800 for that one in a hospital all inclusive?
Yeah, that part I don't know. It's quite possible that number could run higher. It depends on how much you believe the pricing that they post on the website. And I think if you poll people that have looked at those numbers and then did the math afterwards, they don't always align. But I don't know that for a fact. I just heard kind of secondhand information. But in our case, that $2,380 includes literally everything. It includes the facility fee. It includes the anesthesiologist fee. It includes the surgeon's professional service fee. It includes all disposable costs related to surgery. It includes the pre-op evaluation, and it includes any post-op follow-up. And in the event of pathology, it also includes that. So if there's a specimen that's sent to pathology, whether that be a gallbladder or whether it be a skin lesion that's sent for analysis, or whether that just be a polyp from a colonoscopy, all of that is included. So any price that we have posted is included. There's a few exceptions. Orthopedic procedures, sometimes if you get into bigger cases, total joint prostheses, every patient's a little bit different. So you don't always know exactly what prosthesis is going to be needed. But even in that case, we take the price of the prosthesis that we've negotiated with the vendor and include that in the bundle with zero markup. We don't make money off pathology. We don't make money off of the prosthesis that's used or the hardware that's implemented for a surgery. The idea is to pass those savings on to the patient.
Right, and I think Dr. Keith Smith is the same when it comes to orthopedic surgeries. Mm-hmm. He won't do quotes on the hardware because it can always be a little bit different. So, and I think you guys are following his model very closely, if I am correct.
Right. Yeah, we're really kind of similar DNA. Like I said earlier, he's been a great help and also an encouragement throughout this process as kind of the bigger healthcare systems leverage their strength and their finances against this idea. But fundamentally, if you don't introduce some kind of competition into the market, we firmly believe, Dr. Inman and I and Jeff Williams, our third co-founder, believe that we're on kind of a slow march to a single payer system that's probably going to limit accessibility to care even more. Not to say anything about quality. So if we don't try to advance the field and introduce competition and find ways to do things better with better outcomes and better efficiency, and better quality, that I think we're heading in a bad direction. And we always use a simple example. Most people have accepted healthcare the way that it is, but you would never accept that in any other aspect of your life.
No.
Would you ever go buy a car without knowing what it costs first? And would you ever accept the fact that that car costs a different amount for a different person just because of their insurance and circumstances, and everybody's legally allowed to be charged a different price, significantly different price? You'd almost say that's discriminatory. And so I just fundamentally don't believe that's right. And so really we try to build the model to prevent those things from happening.
So I do have a comment
Janet,
before I jump out of here. I think from a healthcare provider standpoint, we see patients that financially can't afford something, put something off because of the access issue. And we were always taught that as soon as you can take care of a health issue rather than prolong it, their outcome increases to be more positive because that issue has been dealt with, i.e. colon cancer. The sooner you find the polyps, the better the outcome for the client. So I think in a provider stance, as a doctor, a nurse, as a pharmacist, we want that patient taken care of in a timely manner, because the more time that's there with somebody with some pathology or something, the less likely we have to have that positive outcome. And so when we're talking about doctors that are doing surgeries and performing them throughout your whole community at different entities, if we all had the same outlook, i.e. the hospitals, the surgical centers, if we all had the patient is our focus to get the health and the wellness for that client versus fighting over the scraps there, because really you're taking care of clients that are not able to access them and they're not able to get the care that they need. And so, it's kind of ironic that we're sitting here talking about, they have to wait for 3 months and then they have to wait for another thing. And, and in that time frame, how long is it before they actually have that procedure that they needed?
Right. That's absolutely true.
So speaking of that, can you give an example? And I'm putting you on the spot, and you might not be prepared for this, and I'm not sure how much, being in anesthesia, that you might or might not know about this, but can you give an example of, a patient that when you were in the system, had to wait weeks or months to get a procedure done, whereas you guys increase access? I mean, you already talked about the two kids with tubes. Maybe you can explain their system a little bit and what kind of, I imagine they tried to access the traditional system first, maybe not. And if they did, what kind of runaround did they get? And what would their time frame have been, and what was yours compared to that?
Yeah, I can give you a couple situations, and some of them run together. So I don't know if necessarily the insurance situation is the same for each of these cases, but they fall into two categories. You have the patients that don't have insurance, and they just need some type of surgical care in the case of ear tubes or whatever that might be. An ear tube or colonoscopy or hernia repair or gallbladder removal. They fall into two camps. One is the camp of, I just don't have insurance and I need to get this done. I'm willing to pay for it, but I just cannot afford, in the case of gallbladder, lap chole, 1 hour procedure with about an hour recovery, that involves a couple small 1.5 centimeter incisions. That cost is $22,000. Well, I say that cost, that is the, after negotiated discounts, the reimbursement rate to the hospital for that procedure. 2 hours of facility time, an hour of surgery, and maybe an hour of recovery for $22,000. Our cost is $8,300, $8,400 for that same procedure. And so the patient can't afford $22,000, frankly. So they just deal with gallstones, and eventually they end up getting, gallstone pancreatitis or other complications related to it. And so that's camp one. Camp two is the people who know that they have health insurance. They pay for it every month. They are relatively healthy families and they don't utilize it. They say, hey, I'm paying $1,000 or more a month for family plan and I have an $8,000 family deductible. I go see my PCP when I can get in, and I use up maybe 5 to 10% of my deductible every year. It's now November and I need surgery, and so I need a hernia repair. Well, in that situation, if they have an $8,000 deductible, that hernia surgery is going to eat up literally every single dollar of that $8,000 and then some, in the current health systems. So they're going to pay almost $8,000 out of pocket. In our case, I think most of depending on the type of hernia, they're going to save $3,000, sometimes $4,000 off that number. So they might choose in November, December to pay $5,500 at Wellbridge, knowing that their deductible is going to reset in January anyway. Right. And so they just save themselves $3,000. They know that they're unlikely to need another surgery in the next few weeks. And even if, in that scenario, you're really functioning kind of out of network, but it only makes sense to do so because they've looked at the numbers and they've, kind of realized that I don't utilize my healthcare plan and I don't want to because it actually is not really providing the needs that I have,
Right. Now, can you talk about how quick you can get somebody in as opposed to if they were going through traditional insurance, they need prior authorization for surgery and all that kind of stuff? How quick can Wellbridge get somebody in after the referral process and all that from a primary care? I know it's a case-by-case basis, but can you give an example?
Right. It's tough. Like right now, it's hard for me to say because we're between Christmas and New Year's. But let's say we fast forward a week and a half and it's first week of January, usually within a week.
Right.
And that's usually a week to surgery. At least we have the capability of doing that right now. And oftentimes the surgeons that we've partnered with will kind of make exceptional block time available or, go the extra mile to try to get these patients in because we found that most healthcare providers want patients to have accessibility to care, but they're forced to operate within the insurance prior authorization system. And when we just come to them and say, hey, we have a patient, they're a cash payer, can you get them in or find a way to make this work? Usually the answer is yes. So usually within days to a week or so.
I love it. I mean, and the fact, Dr. Piniecki, that you even had to say the part about, because we're between holidays and all that, the fact that you're even thinking about a week, I mean, hospital systems, it's months out. Let's face it. I could tell that you were going to be able to get in faster than most hospitals. Now, here's another thing, a question that I have for you. So how does it feel being liberated from the system? How does that make you feel as a doctor?
I appreciate you asking that question because I think that's really what drives most of what I'm doing. And like I said, I hate to speak for Dr. Inman because he's not here, but I know that he feels the same way because we've had this conversation. It is somewhat daunting. It is somewhat very stressful at times, but it is extremely rewarding. And what I mean by that is most people, most physicians, I would say maybe even people that pharmacy may think this way and physical therapists may think this way. You spend a lot of time in school. And one of the things that is nice about the field of medicine is that there is job security. You know that you will be in need. You know that you have a unique skill set that's patients are going to require. And it's nice to know that is something that you can kind of hang your hat on. When kind of going out on a venture like this, you are giving up that security, but you feel like you're doing the right thing. At least I feel like I'm doing the right thing. Every patient that comes through here that kind of smiles and says, "How is it so easy here?" Just kind of reaffirms what we're doing. That patient, those two patients that I mentioned earlier, the two children and family. They literally posted on Facebook an hour after leaving here about how happy they were about their experience. And like I said, we didn't ask anybody to do that. That's just something they elected to do. And so they put a post up for everyone to see to talk about how nice it was to be able to get through a system, have your questions answered, and go through a stressful time with people that really care and make healthcare easy for them.
I love it, and I'm not surprised. I can tell you, being the father of two grown boys now, I know that my wife would have been ecstatic to have some kind of service like that for our two kids. Our latest experience with a hospital with our son when he was 18 years old was not very good. Not surprised, but it wasn't very good. Expensive, poor service, quality, eh. Um, but we want to educate and empower others that there is something different out there. And even if you have traditional health insurance, there's something different out there. Doctors like yourself that have stepped out of the box. And I will tell you that for me as a pharmacist, Jan and I have not billed traditional insurance or insurance at all since 2002. So we've almost been doing free market medicine for 20 years. And I will tell you, it was either we got out of pharmacy because we did not like what was going on, we changed professions, or we did something different. And we love what we do. And yeah, it was scary. And at first, it's still maybe we've been doing it 20 years, so secure. We got a lot of security now. But you're right. That's why a lot of physicians or healthcare professionals don't get out of the traditional system because it's super secure and they're scared. But I got asked one time in Oklahoma when we went to the Free Market Medical Association Oklahoma chapter meeting. Somebody asked me about survival versus thriving. And, we're thriving, but I will say that to me, it doesn't matter because you could not pay me enough to literally to go. I'm in a different place in my career now, but you could not pay me enough to go back to traditional healthcare setting. Literally, you could not pay Janet and I enough because we are liberated. We feel liberated from the traditional healthcare system. And we have colleagues that work in pharmacy that absolutely despise it, whether they work in a hospital system or they work in a retail system, because they have no control over their own job. And you as a physician know how that is when you work in those systems. Here you're the most educated professional in the nation, yet you have very little control over what drug you can use as an anesthesiologist, right?
It's true, and again, I try not to focus on the negative, but when you practice in an environment like you're kind of talking about and been a part of something, you realize that you start to realize that you're perceived as a disposable part of the system. Meaning, it doesn't matter how educated you are, it doesn't matter really even how talented you are, if you don't fit the system and do things kind of the way that the system is asking you to operate, that they'll find someone else with your credentials to kind of plug you in, almost like a cog in a complex piece of machinery. And it was frustrating because these are patients that we're taking care of. It's not like you're stamping out sheet metal or making parts that are inanimate objects. These are actually people's lives. And when I'm trying to make good decisions that really impact their outcomes, when you're told that it costs too much, or that, that's not something that we think we want to do as an entity because of various reasons, they don't even define those reasons, you realize that, hey, this isn't medicine, at least the way that I understood it to be practiced.
Right.
And so just, it's time for a change.
So a couple other questions. You got onto the pricing about, I don't remember if you used the number 40%, but one of the things you said is how your price could change, would be about 40% less based on the already discounted price from the insurance company.
Mm-hmm.
Can you explain, even though it's incredibly difficult, which is exactly what hospitals want, but can you explain that if you're a cash patient going into a hospital, you don't get that insurance discount already. So you'll be paying more already. So your savings is going to be probably 8 times what what the normal cash price would be at a hospital. Can you explain that?
Sure. I can give you another example that may
Good, please.
kind of outline that pretty well. So in Indiana, especially northern Indiana, we have a large population of Amish and Mennonite folks. Those people, when they have surgical needs, they will come usually to Indianapolis because, depending on the surgical needs, there's multiple hospitals outside the city, but if it's a larger type surgery, Indianapolis is the biggest city in the state, and it's kind of the focal point, the hub of that wagon wheel of healthcare. It's tertiary referral centers and whatnot. So oftentimes, if it was a larger orthopedic type procedure, whatever case it was, the Amish families would come to Indy, and I could probably recount at least 5 or 6 times in the last few years of individuals come down and a child needs some type of orthopedic procedure for either a fracture or Achilles tendon lengthening in a younger child, or some type of orthopedic spine procedure, and in those cases the families pay for those out of pocket. And when I say the family, it is like the entire community supports one another in those surgical procedures. And so I'll give you an example. For in an adult surgery case, I think I told you the gallbladder removal is about $22,000 in the city. That is the amount that the insurance company on average pays after negotiated discounts. As anyone that's ever looked at a hospital bill and tried to make sense of it realizes that there's usually a much larger number that's listed above that line item, and it usually is something that's maybe 50, 60, 80% higher. So you'll see a number like $38,000 or $45,000, and then it'll have a bunch of kind of terminology below and about negotiated discount and in-network and a bunch of other kind of arcane terms that will amount to a total that's about $22,000. So if an insurance company, a commercial insurance company, is paying $22,000 for that procedure, that Amish patient might be paying somewhere in that $38,000 to $45,000 range, because the cash payer price, while hospitals will oftentimes give you a 5 or 10% discount, you don't have the benefit of those negotiated terms that the insurance companies have. And so now the cash payer, who happens to be 20, 30, 40 Amish families that are contributing everything they can for an expensive surgery, are forced to pay even more, than an insurance, a commercial insurance reimbursement would be for a patient that has commercial insurance. And in that situation, like I said earlier, our cost is $8,500 more or less for that same procedure. So, how is that fair? It's just not. And they don't, that patient population, the Amish, are wonderful people, and they do not complain. They are hard workers, and they're very thankful for everyone who's cared, when they care for them. I see a situation where they're the most gracefully, gracious people, and I feel like maybe the ones that are some of the most abused in the current system, and no one is making any effort to try to correct that injustice.
Well, you kind of mentioned it a little bit earlier, but it's amazing that it's legal. I mean, I think what these healthcare systems do is they're cartel-like tactics. I mean, they collude with insurance companies to basically screw over everybody besides somebody that's not insured, and they cost shift. And we would not accept it in any other industry, yet we do in healthcare. It's just normal.
Right. I totally agree. The system now is, it's a business that some of these healthcare entities. One of them is a $7 billion revenue company. Another one in our city is a $26 billion a year revenue company. And I don't fault them for being large and successful. But when you're, as a clinician, you're on the ground level, like delivering the care, you see all these people that are being hurt by the system financially, rather than being helped. You realize that, like I said, the system is broken, and we see this as a very straightforward way to kind of increase that fairness.
Right. I agree. And I had a direct primary care doctor that I interviewed last year, I believe, and he said that he thought the only way to fix the system was to get out of the system. That's kind of what you've done, Dr. Piniecki, and I appreciate you for doing that, because you are, leading a revolution in free market medicine, and it's not a flash in the pan. I think it's the future of medicine. Unfortunately, I think we'll always have government medicine somewhere, but I do think that in this country, we are always going to have people that are going to be able to make choices with their medicine, choices, whether it be surgery, whether it be medication, or whether it be what doctor they choose. And you're leading that. So thank you so much for doing that.
I appreciate you saying that. I appreciate it. Yeah, like I said, it's just the ability to hear from patients on a one-on-one basis and individual basis on how they had the option, and how they had the access, and how, we saved them $5,000 or $8,000, and, over what their cost would otherwise be, just kind of adds fuel to my fire, to kind of keep pushing forward with the ideals and the goals here.
For sure. Now, what is your ultimate patient at Wellbridge? Is it a direct cash pay patient? Are you looking for self-funded employer plans? Both? Will you tell us a little bit about that?
Yeah, that's a good question. So the model was kind of built up on the idea that, hey, anybody who needs surgery who otherwise can't afford it, we want to give them an alternative that makes no compromises in quality. In fact, is probably better quality from a facility side and a practitioner side. But it was basically built around the idea that, like, these individual folks, whether that be a cash payer that doesn't have insurance, or whether that be a super high deductible plan who doesn't utilize their insurance and effectively is a cash payer any given year for simple outpatient procedures. That's kind of how we built the model. But as we kind of learned more and expanded upon it, we realized that, there in the state of Indiana, about 70% of companies are self-funded. And basically what that means is that while they have access to the commercial insurance networks, the companies themselves actually pay the claims. So they basically carry the cost associated with that care. And with that kind of number, 70%, it only stands to reason that these companies, if they have an outlet to be able to find quality care for a much lower cost, it only makes, rational sense to be a part of that. And so one of the things that we think is very important is to engage with those companies to try to give them accessibility to the same programs, the same pricing that we do for individuals. And one of the tenets of that is that, we don't negotiate volume discounts. We try to drive our price as low as we possibly can, and everyone pays the same price. And so whether that's a company that has 10,000 employees and maybe sending us 150 or 200 referrals a year, or whether that's an individual mom with a child who comes in and says, hey, I just need ear tubes, it's $2,380. And so we just drive that price as low as we can, and we say, hey, look, this is, in that case, probably 65% less than what the going rate is in the market at large.
I love it. One of the things I like about your model too is that everybody pays the same price. Now, not only is that, I think, more fair, especially when it comes to healthcare, where there is such a range of pricing depending on, what insurance you have. But I think it makes it transparent and simpler for everybody, and especially the patients, but also, even your staff and people that are accessing your services. It's just easy to know that it's $2,380.
Right.
There's no surprises. It's all transparent. It's pretty easy. And I think, that's one big selling point of your surgery center is, here's the price. It's that simple. You can quote that to somebody. It is what it is, right?
Right. Yeah, and we just try to make the whole process easy for them too. One of the things that's under development is a patient portal. So patients will be able to go online. They'll be able to see not only information about us, individuals, those that started the business, but about the surgeons. That will be up relatively soon with surgeon bios. And the patient portal also will include a payment portal. So if patients want to make payments online, they can do that. And so, you don't have to go through all the rigorous and confusing steps of submitting claims and getting approval. It's just as simple as any other purchase you'd make. I mean, you look at companies like Amazon, right? There's no reason why we can't employ these same type of techniques in healthcare.
I agree. So. I agree. We are streaming your website right now. It looks like a great website. And so that's where people that are interested could find out about you, I'm assuming, correct? That's the best way?
Absolutely, yeah. And if you want to, you can click on that pricing there to make sure I'm quoting you correct numbers, because some of them I memorize, some of them I don't. But like I said, we truly want to be transparent. There's anybody can see these, including the hospital and any other competitors that we would possibly have. But yeah, you literally can see there, there's the price for the BMTs, 2380. So I got that one right at least.
It's awesome. It's awesome. I got to tell a quick story. So, as you know now, Dr. Piniecki, if you call, your average doctor that works at a hospital type system and you ask them the price for something, the first thing they're going to ask you is that they have no clue. And even their staff
Right.
is not going to have a clue. And I think the doctor not having a clue is a problem. A lot of doctors
Yes.
say, well, I don't want to know about pricing. And I know pharmacists hide behind that too. And I was actually taught in pharmacy school that we shouldn't have to worry about prices. Well, it's just reality. We should have to worry about prices. And that's okay. And then the patients will get better service that way. When I first got out of pharmacy school, there was no Medicare Part D pricing, or there was no Medicare Part D coverage yet. So there was no drug coverage for seniors yet. So pharmacies had to be ultra competitive with pricing. I worked for a retail pharmacy right out of school, and all the retail pharmacies were ultra competitive because they had to be. And then Medicare Part D came into play in 2007. I wasn't playing their games anymore, so I wasn't there. But the year Medicare Part D came into effect, drug pricing went up 19% one year. And that should be a clue to a lot of people what goes on when insurance companies, especially the government, gets involved. And then now you call an average pharmacy and you ask them the price of medication, they have no idea. They have no idea. And they say, well, it depends on what your insurance. No, you didn't hear me. I don't have insurance. I'm paying cash. Well, we don't really know. And it's like, I think doctors and pharmacists should know the prices of services. That's just reality, right?
Right. Yeah, actually that's kind of a risk with our business model, and that you have to kind of know the business of medicine. You have to know what it costs to deliver care, and just so operating on a patient, obviously a very complex process and a very high-tech building, with high-tech equipment, but you have to think about that. What does, a 4x4 dressing cost? What does a sling cost? I mean, all those things have to be accounted for when you're delivering that care. So yeah, you have to be intimately knowledgeable about all of that, to make sure that you want to be fair to the patient. And my goal personally is to drive the prices as absolutely low as I can, just to demonstrate to patients as well. And Dr. Keith Smith talks about this, like, hey, this care can be delivered. Surgery is expensive. It is not nearly as expensive as what you've been paying.
That's right.
We try our best to actually prove that in the pricing model. And we're kind of challenging people by putting it out there, like, hey, you don't have to call to get our prices. Just go on the website. You can see there's over 300 CPTs built out, and there'll be a couple hundred more over the next coming months as we add procedures as well.
That's awesome. That's awesome. Well, thank you for being on, Dr. Piniecki. Our goal at Health Solutions is to educate and empower people to take charge of their own health. And part of that is financial. That's the only way it's going to fix the system. And I believe it's going to be from the bottom up. Empower patients to make their own healthcare choices. And you're part of that. So thank you so much.
Thank you so much for having us.
Yeah.
And I appreciate you having an interest in hearing about our model. And yeah, we look forward to future conversations.
Yeah. So as we wrap this show up, what do you have a passion for?
My hobbies are pretty varied. If you're talking about personal hobbies outside of medicine, I just got back 2 days ago from Disney. I promised my family when we started this business venture, the modeling 4.5 years, 5 years ago, the actual physical purchase and building of the building about 2 years ago. We haven't done much in the way of vacations. So, my wife and I have 2 kids. We enjoy traveling. So Disney was our trip of choice.
Awesome.
This go around. So I do enjoy that. I do a little bit of working in the garage, a little woodworking. I have, some varied hobbies, and, I have a little home theater in the basement at my home that I like to tweak on and work on.
Oh, I love that. We'll have to discuss our home theaters. I love music. I'm an audiophile, and I love my home theater. Yeah. I
say it's my little getaway.
Yeah. So I was making a joke to one of my friends who's a musician, and he knows music, and we talk music sometimes. And he talks like guitars and gear and stuff, and I talk stereo equipment. And I sent him a text. I said, if you're waiting for any last minute Christmas shopping ideas for me, here's a fully decked out Macintosh home theater that you could buy for me.
There you go. There you
Right?
go. Yep.
And it was like $400,000, just in equipment.
I can believe it.
Yeah, he didn't take me too seriously.
Gotcha.
So yeah, no, I appreciate you being on, and you've definitely realized our goal today. And yeah, let's stay in touch, because I want to keep in touch with you and see how your surgery center goes as you guys progress. So thanks for being on today, Dr. Piniecki.
Yeah, thank you for having me.
Yeah, you're welcome. So Thursday, tune in. We will have Dr. Kathleen Brown. She is a dermatologist, and she's a cash only dermatologist, and she got out of the traditional system too, so she can help patients and save them money. So you don't want to miss out, because she's going to be talking about skin cancer, which when we think about cancer, we always think about how expensive it has to be, and she's going to give us some less expensive alternatives at better service and better quality. So you don't want to miss out on that. 8 a.m. Pacific Standard Time this Thursday. Tune in, and thank you for listening to Health Solutions with Sean and Janet Needham. Thank you, Dr. Piniecki.
Thank you.